Okay, so in the interest of time, let's go ahead and get started. Good morning, everyone, and welcome to the April Tarjan Center Distinguished Lecture Series. I'm Dr. Jasper Estebillo, Training Director for the Tarjan Center, and it's my pleasure to be here with you all and to introduce our speaker, Hilary Schiltz. Hilary is a clinical psychology intern in the Autism and Neurodevelopmental Disabilities Assessment track at the UCLA Semel Institute for Neuroscience and Human Behavior. She's also a doctoral candidate in clinical psychology at Marquette University. She's currently involved in the Child and Adult Neurodevelopmental Clinic, or the CAN Clinic, as well as the Peers Clinic at UCLA. Hilary completed her master's degree in child development at the University of California, Davis, and was a trainee in the LEND, or Leadership Education in Neurodevelopmental and Related Disabilities program in Wisconsin. Hilary greatly enjoys being involved in the autism research community. She has been an active member of the Student and Trainee Committee for the International Society for Autism Research. And at the INSAR annual meeting this year, she'll be leading a special interest group focused on improving patient-reported outcome measures in autism research. Her research interests are largely centered on the measurement, trajectories, and mechanisms of well-being among autistic youth and adults within various family and social contexts. She's delighted to talk with you today about measurement in autism. A few reminders: please type your questions into the Q&A function for us to discuss at the end of the talk. And please remember to complete the evaluation survey, which you'll find in the chat as a Qualtrics link in just a moment. As we complete this year's lecture series, we would also love to hear from our attendees on what topics you'd like to see for next year. So please do include that in your feedback. It's very valuable to us. And with that, please join me in welcoming our speaker, Hilary Schiltz. Thank you, Hilary.
Hello, everyone, and thank you so much, Dr. Estebillo, for that very kind introduction. I'm very excited to talk with you all today about measurement of mental health in autistic people, and in particular, focusing on where the science is at, talking about implications and the role of measurement for both research and clinical practice, and going over some recommendations for the future. So first, I'd like to acknowledge my wonderful colleague, Dr. Alana McVeigh, who has co-developed and previously presented some of these slides with me. And I also have many people listed here that I'd like to thank for teaching me and fostering my interest in this topic. And I have no disclosures. So first, just a note about language. So I will be using identity-first language throughout this presentation. And that is because of recent evidence that self-advocates have a preference for identity-first language, and because of recommendations related to avoiding ableist language in autism research. So first, I'd like to highlight the learning objectives of this talk. So I hope by attending this talk, you'll be able to first describe at least one reason why accurate measurement of mental health and related factors is so important for both research and clinical practice with autistic individuals. The second objective is to be able to identify and define what makes a good questionnaire. And lastly, and focusing on next steps, is to be able to describe at least one way that researchers and clinicians can work to improve measurement in this population. So in order to meet those learning objectives, this talk will be grouped into 3 content areas. So I'll start out by talking about autism broadly, including autism symptoms and what we know about mental health in autism. Then I'll focus specifically in on measurement, including the role of measurement for clinical work and autism research, the qualities of good measures, some of the challenges and barriers to good measurement in autism, and then some example measures and research studies. Finally, we'll wrap up with identifying future directions for researchers, clinicians, and stakeholders. So diving into some of the background on autism and mental health. To start with, I wanted to provide just a brief overview of the symptoms of autism. So autism is characterized by 2 core domains of behavior. One is differences in social communication in a neurotypical majority society. And the second domain is restricted or repetitive behaviors or interests. So we know that these symptoms can be related to mental health challenges among autistic people, which I'll talk more about on the next slide. So research shows us that there's a high rate of mental health concerns among autistic individuals. So this includes depression, anxiety, suicidality, among others. So for example, the lifetime rates have been estimated at approximately 42% for anxiety and 37% for depression, compared to 7 and 9% respectively in non-autistic samples. Some potential explanations for these high rates include things such as social experiences like rejection or loneliness, emotion dysregulation, and neurobiological differences, all of which may also be impacted by mental health. For autistic individuals, these co-occurring mental health conditions can be more distressing and have a greater impact than core autistic characteristics on quality of life and other outcomes, such as adaptive functioning and employment. So taken together, this research really suggests that mental health in autism is an important area of research. But what lies at the foundation of research is good measurement. So this talk is titled Mental Health and Related Factors because today I'll be focusing specifically on these domains and thinking about how we can best capture the lived experiences of autistic individuals in these specific areas. So to focus in on measurement, we know that in order to better understand mental health among autistic people, we first need to be able to measure it. However, there's a lack of evidence for many tools used to measure mental health and related factors in autism. Therefore, advancing measurement in autism has been identified as a top priority both by researchers and by stakeholders. So this has really been echoed across different individuals. So we know that sound measurement is the foundation of good science. And within autism research on mental health, we need good measurement for a number of reasons. So this includes being able to identify how common co-occurring conditions are, for exploring mental health conditions and how they emerge over time. So what mechanisms and pathways may underlie mental health? For examining patterns of co-occurring conditions and factors that may place people at greater risk for mental health conditions. And finally, to evaluate whether treatments work and how they work. In terms of clinical practice, good measures are also important for both assessment and for therapy. Regarding assessment, it is important for diagnoses, so differential diagnoses or just diagnostic clarity, and guiding treatment recommendations. So what would be the next steps after the assessment process? In terms of therapy, good measurement is important for identifying treatment targets. So which specific areas are the most in need of support? Where are the weaknesses that we need to really intervene with? And for monitoring treatment progress and outcomes, making sure that we're on track and we're targeting and improving the areas that we need to. So overall, we know good measurement is important, but in psychological research and practice, we can't measure things like anxiety or depression as we would something like height or weight. So we can't set someone on a scale or use a tape measure, but what we can do is ask people about their experience in a number of different ways. So this includes either having the person or someone else that knows the person complete a survey or a questionnaire. Could also involve conducting interviews, which may be structured, semi-structured, or unstructured, or observing people. So today, what I'd like to focus on are questionnaires. So these are things that are reported directly by the person or other informants. So questionnaires are an important focus due to how commonly they are used, how easy they are to administer, and generally the cost effectiveness. So not only are these a great tool to use in research and clinical practice, but they offer an important perspective into the person's own experience. So when we think about questionnaires, there are certain qualities of the measure that make it a good measure. So we call these psychometric properties. In particular, a few key pieces that we want to strive for are that the measure measures what it's supposed to, that it works consistently, and that it captures change. So we'll get into some of the details of these components in the next few slides. So a measure needs to measure what it's supposed to measure. So by this, we mean, are we hitting the bullseye of the target? We call this validity, and there are many different kinds of validity. So for example, we want to know that the questionnaire is associated with other things that it should be associated with and not things it shouldn't. So an example is for a measure of depression, is it related to quality of life? We also want to know if the measure captures multiple aspects of a construct. So for example, does a measure of anxiety capture social anxiety, generalized, separation? And how are those things related to one another? We also want to make sure that it correctly classifies people. So do people with anxiety score above the clinical threshold on this measure? And do people without tend to score below? And finally, we want to know that it covers all aspects of the construct. And this component in particular is important to think about related to autism research. So we need to make sure that there are all aspects of mental health being captured by our instruments. And we know based on previous literature and previous research that there may be aspects that are unique to autism that aren't captured by existing instruments. So for example, in anxiety, there's evidence that there may be fears that are not commonly observed outside of autism. For example, anxiety around routines, novelty, or specific interests. Additionally, we want to know whether there may be differences in the way people answer items on questions, both across the spectrum and between autistic and non-autistic individuals. So when items or questionnaires demonstrate systematic differences based on factors outside of the intended construct, this is called differential item functioning or measurement invariance. So these are both two approaches to kind of ask these questions. In addition to validity, we also want our measures to work consistently. So that is, are we hitting the target in the same place each time? And this is called reliability. When we think about reliability, we want to make sure that people respond similarly over time. So if we give the measure a couple of weeks later or a couple of months later, are they still answering questions in the same way? And whether people respond similarly across items within the measure. This is called internal consistency. Another component of measurement is that it detects when the construct changes. So especially when we are intervening and providing treatment. In clinical trials, we want to make sure that the measures we use are able to pick up on changes from pre to post intervention and even beyond. So we want measures that have all of these good, strong psychometric properties, as we just discussed. However, there are specific barriers and issues that may get in the way of good measurement in autism. So generally, kind of across reporters, most measures were developed or normed with the general population. So this means that oftentimes there may be particular features of the questionnaire that may not be accessible or well suited for autistic individuals. So this could be how the questions are asked or the options for responding. And we also know that there may be autism-related experiences that are not captured by these tools. So without testing these instruments, we don't know if they work in the same way in autistic individuals as in the general population, and we shouldn't assume that they do. With respect to self-reported questionnaires, we know that there's a higher rate of something called alexithymia in autistic individuals. So this is difficulty with identifying and describing internal experiences. This may make it more challenging to report on something like worry or sadness. We also know that autism is a spectrum, meaning that not only are there a range of strengths and weaknesses with respect to core autism symptoms, but also in terms of verbal and cognitive abilities. So self-report questionnaires really need to be tailored to be accessible by people with a range of cognitive and verbal abilities. Finally, in terms of other reports, although not necessarily unique to autism, when caregivers or other people are completing questionnaires, they necessarily have to rely on externally observed behavior or something that the individual has shared with them, and that may or may not reflect that person's internal experience. Additionally, there's some evidence that it can be challenging to really tease apart features of autism versus features of another condition. And this is sometimes called diagnostic overshadowing or diagnostic overlap. So related to those issues, there was a paper published recently that identifies kind of particular issues, lessons, and recommendations related to making questionnaires accessible for this population. So I'd like to provide a snapshot of just some of those lessons and recommendations here. So first, many autistic individuals identified complicated or confusing terms or phrases. And a potential solution that was recommended was to either just substitute or change out the term or phrase, or to use something called a hot link, which is kind of a clickable link that then provides a definition or provides examples to help clarify. An example of this is for the word lonely, which then had a hot link and defined lonely as the feeling of being alone when you do not want to be alone. Another issue that was identified was in the options for responding to questions. So these often involve selecting from choices such as a little of the time or sometimes, most of the time, which can be really difficult to interpret. What does that mean? So a possible solution is to use graphics or percentages to provide some clarity on what the writers of the questionnaire intend these response options to mean. So here's just an example of a graphic that could be used to depict none of the time, a little of the time, or some of the time. Another concern was related to anxiety around answering questions accurately. So for example, how many times they visited a mental health provider? It might be really hard to remember exactly how many times that was. So the recommendation here could be to remind the respondent to just give their best guess, or to allow comments, kind of a comment box where they could share other thoughts or questions about the items. So an example is to please give your best guess from the provided answers. And finally, as I mentioned before, it might be that the questionnaire just doesn't fully capture the intended construct. So we may need to add items as necessary. So an example here would be adding other items about sensory sensitivities or communication skills. And of course, this would be best accomplished with stakeholder input, which we'll talk a bit more about in a couple of slides. So although very few questionnaires have been adapted or thoroughly validated for use with autistic individuals, this area of research is growing, and there are a few questionnaires and studies that I'd like to highlight that have specifically developed or adapted a measure for autistic people. So the first of which is called the Emotion Dysregulation Inventory. And this measure was created by Carla Mazepsky at the University of Pittsburgh and is a caregiver report measure for youth that's intended to capture both emotional distress and problems with emotion regulation. And this measure in particular was created using PROMIS guidelines. So PROMIS stands for Patient Reported Outcome Measurement Information System. And these are a set of guidelines that were developed by an NIH roadmap initiative for good measure development. So although the PROMIS guidelines or process is quite extensive, and I won't go into all of the details here, I did want to highlight just a couple of key steps. So one of which includes defining the target concept. So what are we trying to measure? Making a conceptual model of the construct. So which different aspects of the construct exist, and are we capturing everything? And then getting feedback on the model from stakeholders. Then creating a set of items or questions based on existing measures. So pulling all of those items together and then adding in any new items as needed. Another component is something called cognitive interviews. And this is where people read and think out loud while completing the questionnaire. So this kind of shows what is the thought process as someone is responding to these items. And then of course is pilot testing of the measure, followed by larger scale testing, including using item response theory. So this process has been found to produce measures that assess a wide range of functioning and are remarkably precise. So another measure that I'd like to highlight is a self-reported measure of quality of life. So this is the World Health Organization Quality of Life brief version. And this has had questions added to it, so a supplement to reflect autism-specific quality of life. Although it's important to note that the investigation of these items subsequently revealed that these items might underestimate quality of life, specifically in autistic women. Additionally, I'd like to highlight 2 questionnaires related to anxiety that have been developed or adapted for autistic people. So the first is the Parent-Rated Anxiety Scale for ASD. And this is a parent-reported questionnaire intended for youth, and it was developed using both focus groups and IRT. And second is the anxiety scale for children with autism spectrum disorder. So this includes both parent and self-reported versions, is intended for youth, and was adapted from the revised child anxiety and depression scale. So in the adaptation, items were both reworded and there were additionally new items added. So in addition to measures being developed or adapted for autistic people, multiple questionnaires have also just been evaluated. So investigated to see how they work when administered to autistic people. So one of which is the Suicidal Behavior Questionnaire Revised. This is a self-report measure of suicidality for adults. And results of this study that was led by Dr. Sarah Cassidy showed that the measure did not perform the same in autistic and non-autistic samples, and that many of the items on the measure were actually interpreted quite differently than intended by the creators of the questionnaire. So therefore, this measure was then subsequently adapted for autistic adults. Another measure, the Beck Depression Inventory, is a self-reported measure of depression for adults. And a study led by Zachary Williams at Vanderbilt demonstrated that the measure has good psychometric properties in autistic adults. And he even developed a scoring program to use based on IRT analyses. Related to anxiety, Dr. Brooke Metness and I conducted a study of the caregiver report version of the Screen for Anxiety-Related Disorders, or the SCARED. And we demonstrated that caregivers actually respond differently to some items based on their child's autism symptoms, their child's IQ, or how old their child is. And one last example is a study of the difficulties with emotion regulation scale, or the DERS, that colleagues and I conducted. So the DERS is a self-report measure that was completed by adolescents and adults. And generally it showed good psychometric properties in an autism sample. Although it's notable that some items on this questionnaire were actually found to belong to different subscales than on the original. And we kind of suggested that it shouldn't be used unless these modifications are made. So I also want to walk through some findings from a study that colleagues and I conducted on the social anxiety scale for adolescents. So to provide just a brief overview of this measure, this includes both an adolescent and parent report version, has 18 items related to anxiety, and those items are rated on a 5-point Likert scale from 1, not at all, to 5, all of the time. And in the general population, this measure is found to have 3 subscales. So one is the fear of negative evaluation subscale. So this includes items like, I worry that others don't like me, as well as 2 subscales that are related to avoidance and distress. So one is more general and one that is more specific to new situations. So this measure, the SAS-A, has been used in autism research to examine both the prevalence of social anxiety as well as the behavioral and neurobiological correlates of social anxiety. So in our study, in a sample of 197 adolescents and caregivers, we analyzed a couple of different dimensions of this measure's performance. So one was the agreement between adolescent and parent report on each item. We also looked at the factor structure or dimensionality. So what components make up this measure and how are those related to one another? We looked at measurement and variance across reporters, so between adolescents and caregivers, as well as validity. So our analyses revealed poor agreement between adolescents and parents on many of the items. So what this suggested to us is that parents and adolescents may either experience or perceive the adolescent social anxiety differently from one another. We also found evidence instead of a 3-factor solution for a 2-factor solution. So that was, there still was the fear of negative evaluation, but there was a broader social avoidance and distress measure that captured both that generalized social anxiety and distress as well as to novel or new situations. And related to measurement and variance across parents and adolescents, we found a lack of evidence for measurement and variance, which really means that the measure might function differently depending on whether it's an adolescent completing it or a caregiver completing it, which tells us that those 2 things really shouldn't be compared to one another. And with respect to validity, we found some evidence of both convergent and divergent validity based on correlations with measures of anxiety, measures of depression, and autism symptoms. So I hope that this study really highlights the importance of examining how a questionnaire works within autistic people, rather than assuming that it works in the same way as it did in the general population. So I'd like to provide kind of an overview of some recommendations and future directions. So first, I thought I'd highlight some areas that we know more about, and then I'll talk a little bit about some of the gaps or things that we know less about. So in particular, we tend to know more in this area about anxiety as opposed to other constructs like quality of life, loneliness, depression. We tend to know more about child report or measures intended for youth. We tend to know more about measures that are completed by caregivers as opposed to self-report. And we tend to know more about measures and how they perform in people without intellectual disability. So on the flip side, we know less about other constructs. We know less about measurement properties in autistic adults. We know less about self-reported questionnaires and less about people with intellectual disability. So moving on to some recommendations, in particular for researchers, and some considerations when selecting measures for studies. So first is to choose measures that have psychometric support in autism. So kind of based on the evidence, is this measure valid and reliable in autistic people? If that's not available, second is to make evidence-based adaptations as necessary. So an example is on the DERS, using our scoring instead of the traditional scoring that was developed in the general population. And last is to always use a multi-method, multi-informant approach. So by that, I mean to gather information from multiple sources using multiple different means. In terms of future directions for researchers who are specifically interested in conducting measurement research, I'd recommend doing more research on measurement, and in particular, evaluating measures that exist, and when necessary, either adapting or developing new measures for autism. Second is to focus on those areas that I identified that just have less evidence overall. So that is adults, individuals with intellectual disability, measures that are self-report, and for things outside of anxiety. Additionally, involving stakeholders is a really important component of this. So using focus groups or cognitive interviews to make sure not only that we're capturing all of the construct that we should be, but also that we're measuring the things that are important. Additionally, using advanced psychometric approaches such as IRT can be a really important piece of this research as well. So this allows us to test for things like bias. So comparing autistic versus non-autistic respondents, as well as across autistic individuals. So looking at things like IQ, race, gender, and how those different dimensions and identities might impact measurement. And one example approach that I had mentioned previously is the PROMIS method. Now, thinking about clinicians and clinical practice, some considerations when selecting a measure to use in clinical practice are to try and choose measures that have psychometric support in autism. And similar to the recommendation for researchers is to use that multi-method, multi-informant approach. So gathering information from the person themselves, from caregivers, other reporters, and using multiple different questionnaires. And some considerations or recommendations related to administering the measures. One option might be to complete the measure with the client. So sitting next to the client, for example, having the client fill out the questionnaire and saying, please let me know if I can clarify any items or if anything is confusing. That way, you kind of know what the client is thinking about as they're responding to things, or if there's anything that might have been unclear. Another option is to provide kind of a visual response option. So similar to that graphic with kind of the cylinders that were partway full, all the way full, not full, to kind of communicate what the different response options mean. And last is to just ask clients about their experience completing the questionnaire after they're done. Did you come across any questions that were confusing, things that didn't quite make sense, or you weren't sure how to answer? And this can start a dialogue between you and the patient about their experience to make sure that you're really capturing all of their experience related to the construct. And some future directions related to stakeholders, and that is so autistic people and their caregivers, is to be involved in studies to help both researchers and clinicians to improve measurement. So what things should we be measuring? Are we measuring the right things, or are there things that we're not even thinking about that we should be measuring? And what aspects of your experience aren't captured by existing measures? So are there other items or other questions that we should be asking about this? So overall, I'd like to kind of sum up some takeaways. So first of which is that good measurement is really important. It's the foundation of both good science and good clinical practice. But there are certain qualities of measures that we can test to ensure good measurement. So that is validity, reliability, and sensitivity to change. However, there are some barriers or things that might make that difficult. So that brings us to kind of next steps. So there's really that need for researchers, for clinicians, and stakeholders to all work together to develop, test, and use measures that have good psychometric properties. And ultimately, the goal is to improve quality of life among autistic people. And if this is a topic that you're interested in, colleagues and I will be leading a special interest group at the International Society for Autism Research annual meeting in this coming May. So here is the title and the date and the time, and you can find more information on that website there. So here are all of my references, and I'm happy to answer any questions that came up.
All right, thank you, Hillary, for that excellent talk in covering the broad scopes of the state of the science, as well as future directions and takeaways for researchers, clinicians, and stakeholders. Another reminder for our attendees to please include your questions into the Q&A function, and remember to complete the evaluation survey before you head out. We do have a few questions in the Q&A, but I would like to kind of start us off more so for those of us in the audience who are less familiar with IRT. Hillary, can you give us kind of just more of a background on what IRT is more broadly in terms of science?
Of course, yes. So IRT is kind of a newer approach to psychometrics. And in particular, when we think to kind of the original testing theory, it's a bit more kind of direct. So with IRT, what we're doing is we're estimating kind of, we're taking into account how different people respond on measures, both in terms of kind of where they fall on the construct that we're measuring, and kind of how different items perform. So it's a bit more kind of a fine-grained analysis, I guess, of the different questionnaires, and allows us to ask questions that we can't with traditional approaches. So questions, like I had mentioned, about item bias. So thinking about if there are other things that might be affecting measurements. And that's really something that we can't ask with other approaches.
Absolutely. So more so like being more specific and personalized in the way that the respondents are answering all of these questions, which I think has been quite an issue in terms of measurement up until this point. I also love the takeaways for administration for clinicians as well as researchers. I think as we move towards this world that's more equitable, hopefully, and more responsive to the disabled community, and just the combinations that are helpful for people. I love those recommendations to use those visuals, and being more responsive to people who are answering questions. I think as researchers, we've always been trained that self-report always has bias, but now we want to account for that and to address that through things like IRT and getting at the content validity, as you had said. Great. Okay, so I'm going to jump into some of these questions that are popping in from our attendee, Matt Cohen. Matt asked, does your study include any data or observations about medications that were taken by the participants?
That's such a good question, an important kind of factor to take into account, especially if the medications that are being taken are for the construct that you're measuring. And actually, so in the couple of studies that I mentioned, we really didn't investigate that question about medications and how that might have affected responses. But Matt, I think that's a really excellent question and something that we should investigate is how that might play a role.
Certainly. And I think, Hillary, as you had said, always taking that multimodal, multi-informant approach and including additional information about medications, additional treatments, other comorbid diagnoses. That's always important when we're doing this kind of work because, it's very rarely that an individual just has one presenting concern or problem. And all of these concerns are going to impact each other over time. So I think, as Hillary had said, getting all of this additional data and seeing what's going to be the most sensitive in terms of measurement is really what we need to be considering overall. Mahima Rupasinghe asked, do these questionnaires have yes or no options? I know that, Hillary, you had talked about Likert scales and different ways that informants are able to respond, but I think this question is more so asking about perhaps the measure that you worked on, the SAS-A, or additional kinds of questionnaires if you're familiar, if they have yes and no options.
Yeah, that's a really great question, thinking about the different ways that people can respond to items. And the ones that I specifically talked about do not have just kind of a yes or no option or a don't know option. But I really love the idea of having that, like, I'm not quite sure option. Maybe I'd like to provide a bit more information about that, especially for clinical practice, when you can ask and talk more about what was it about that question that you weren't sure about, or to kind of start that conversation.
Absolutely. Let's see here. Oh, okay. Another question from Mahima is, some carers may have autistic features themselves, and would this potentially be a confounding or an impacting factor?
Oh, such a great question. I don't know of any research that has asked that question, but I think it's a really important area to research more. There are kind of more symptoms of autism found in relatives. And so I would imagine that that might impact kind of how they're responding to items, especially if they're related specifically to social communication or some of those other factors. But I don't know.
Well, I know, I agree. I think that is certainly something to be considered. As we know, there's broad autism phenotype and more broader autistic traits that exist in the population, particularly as we think about autism existing in this world of neurodiversity. I think a follow-up question that I have, Hillary, is if you're familiar, or if any of these scales that we've discussed include other validity scales like negative response bias, or those kinds of validity scales that we like to see in any type of informant report measure.
Yeah, that's a really great question. And I'm thinking through the ones that I talked through today, and none come to mind. But I think that might be kind of that nice addition. So something else that we might want to incorporate into some of these measures. Kind of, yeah, like you said, that validity. Is there any indication on this that it might be biased in some way? And how do we know, and in what way?
Absolutely. And as you've highlighted, Hillary, this area of research is such in its early stages, as many components in autism research are. And so these are questions that are necessary to be addressed as we continue forward. From Deborah Krakel, are you aware of any studies or research that show a relationship between previous treatment, for example, early intervention, using other evidence-based practices such as ABA, and a lower impact or prevalence of co-occurring mental health conditions such as depression or anxiety in autistic individuals? So maybe predictors of EI-BI for these long-term outcomes in older individuals.
Oh, that's a really interesting question. And I don't know, I don't have kind of the the knowledge on that to answer that specific question. But one thing that does come to mind related to that is that we know that interventions kind of for adolescents and young adults that provide kind of social skills and kind of promote social competence are found to impact mental health outcomes. So things like lower depression, lower social anxiety, and less suicidality pre to post intervention. So kind of intervening kind of later in development, I know a little bit more about, but a really interesting thing to look into more.
Absolutely. Thank you, Deborah, for that question. And I think, perhaps future speakers can speak to long-term treatment outcomes. I would certainly be interested to know as well. Let's see here. Another question from Matt Cohen with regard to measurement. What important factors or variables are hard to quantify? So maybe getting at the flip side of things, what other aspects are difficult for us to measure?
Yeah, I think a couple of things come to mind that are just hard to measure in general. And one of which is, I think loneliness is something that I've been really interested in lately. And I think can be especially hard to measure just because it's so hard to kind of describe and kind of quantify. And that's also kind of a construct where we really have very little evidence about good measurements, especially in autism research. Another one is quality of life, I think can be tricky to measure, but is a really important one. Although there was just a study published a couple of days ago that I still need to read in detail about quality of life and measurement in autism. So I think we're making progress.
Absolutely. And I think, Hillary, to that end with loneliness, I think that really the only other area that I'm familiar with that has done any type of work on measuring loneliness has been in serious mental illness, so schizophrenia. And so it's certainly also in its infancy in the world of autism too. But that's a wonderful question. Let's see here, other questions. We already answered this. The presentation will be available on the Tarjan website. So for any of our attendees, the recording of our talk as well as Hillary's slides will be available on their website, and that will be sent out. Okay, and then I think, in terms of additional questions that I have, Hillary, you had addressed some kind of challenges in terms of doing this work, but outside of those difficulties specifically with measuring constructs, what are some barriers in doing this type of work in the future? Right? We want to have a lot of information and we want to have multiple reporters, but what are some of those things that are getting in the way of doing this work for in the future?
Yeah, definitely a number of kind of methodological things that make this work really tricky. A couple of which are that for some of these analyses, you really need really large samples. So we're thinking of at least about 1,000 people responding on these questionnaires, which can just be really time intensive and effortful to collect. And we also want samples that are not only really large, but really well characterized. So by that, I mean, we want to know kind of diagnostically in terms of cognitive functioning, adaptive behavior. We want to know who is answering these questions, which makes, again, it's just more time intensive to be able to have all that information. So I think those are some of the things kind of methodologically that make this work really hard.
Yeah, absolutely. So getting a lot of respondents, a lot of data, so that way we can kind of do the analyses that are necessary to quantify and analyze these types of outcomes as well. Okay, and then see here, Jeanette Ashworth said, can you say more about the recent quality of life study that you saw? I've been eager to read more about work in this area. Thank you for this talk. Look forward to watching in full. And so I know, Hillary, you had said that you had flagged it, but maybe if you know who the authors are,
yes,
and then we can direct them to this paper.
Yes, I believe it was led by Zachary Williams, who's an MD PhD student at Vanderbilt, and he's actually co-leading the special interest group with me. So he's done some really amazing work, and I believe it was the Promise Quality of Life Scale, I'm pretty sure. But it just came out a couple of days ago, so.
Great, thank you, Hillary. Okay, my last call for questions in the Q&A before we wrap things up. Okay, and so let's go ahead and transition into kind of next steps. Hillary, I know that you have a special interest group that is coming up. So if you'd like to go ahead and pull up that slide and let us know where we can see you or find you at the upcoming INSAR meeting, that would be wonderful.
Yes, absolutely. So here is the information about the special interest group. So this will be taking place on the Saturday morning of the conference. And it's led by myself and Zachary Williams. And we have kind of a number of different faculty advisors helping support us as well. So hope to see and get to connect with some of you all there.
All right, okay. And for all of our attendees, please make sure to fill out your evaluation surveys. The link should be in the chat. Please do include in the comment section any ideas of topics that you would like to see for our upcoming lecture series. I am reaching out to presenters for the next academic year's talk. So any ideas or topics that you're interested in, please do include those in the comments, because those are very helpful for me in terms of booking speakers for us moving forward. And thank you again to Hillary Schiltz for this wonderful presentation on kind of the state of the science and measurement in autistic individuals. And thank you for our audience for being here today. We look forward to seeing you at next month's talk. All right, bye everyone.